For my topic, I picked multiple gestation, specifically twins. The goal for the patient is to prevent and treat problems that infringe on the development and birth of normal fetuses, and to carry the fetuses as close to term as possible. Women with multiple gestation have more frequent prenatal visits than single pregnancies due to the higher risk. The average gestation for twins is 37 weeks. 60% of twins are preterm. The average birth weight for twins is 2.5 kilograms. There are two different types of twins. One is monozygotic, or identical twins. This occurs randomly. It occurs in approximately 4 per 1,000 live births. The number of amnions and chorions present depends on timing of the cell division. The other type is dizygotic or fraternal, where two ova are fertilized by two different sperm, and the fetus each have their own placenta, chorion, and amnion. There are some factors that increase the risk of dizygotic twins. They are women of greater age, increased parity, ethnicity, especially of African American descent, family history of twins, especially on the mother's side, and in vitro fertilization. Chorionicity, amnionicity, all depends on the timing of cell division. If division occurs within 1 to 4 days, it results in a dichorionic, diamniotic twin, where there's two placentas and two amniotic sacs. If division occurs within 4 to 8 days, it results in monochorionic, diamniotic twins, where they share a placenta but they have their own amniotic sacs. If division occurs within 1 to 2 weeks, it results in a monochorionic, monoamniotic twins, where they share a placenta and share an amniotic sac. If division occurs within 2 weeks, it results in conjoined twins. And this is less than 1% of monozygotic twin pregnancies. So there are some complications that occur in monochorionic twins where they share a placenta. One of those is twin-to-twin transfusions, or TTTS. This results in abnormal placental vascular anastomosis, where one twin receives more perfusion than the other, and it results in growth discrepancies between the two fetuses. This often necessitates preterm birth by C-section. Twin anemia polycythemia sequence, or TAPS, is similar to TTTS, where there's an abnormal placental vascular anastomosis. But the rate of transfusion is slower, and one twin develops anemia and the other twin develops polycythemia. In twin reversed arterial perfusion sequence, or TRAPS, one of the fetus's heart is not well formed, and the superficial artery-to-artery placental anastomosis provides perfusion of a cardiac twin by the donor twin. Another complication is demise of co-twin or vanishing twin syndrome. Here's a picture of TTTS, where one twin definitely had more nutrients and perfusion than the other. An antepartum maternal implication of twin pregnancies. One is hyperemesis gravidarum. This is due to the increased levels of HCG. And some interventions for this, you want to restore their electrolyte imbalance, control vomiting and dehydration, and if it's severe enough, the patient may require some IV fluids to replace those electrolytes and fluids lost. Another implication is hydramnios. This is common in multiple gestations, and it may not be an indicator of problems with the fetus as it is with single pregnancies. Some other implications are preeclampsia and eclampsia. This is a big one. Multiple gestation pregnancies are 2 times greater risk for these than single pregnancies. Some interventions for preeclampsia and eclampsia is you want to have the patient in a left lying position. This decreases the pressure on the vena cava. It increases the venous return, increases circulatory volume, and placental renal perfusion. You also want to get daily weight of the patient. A weight gain of 3 pounds in 24 hours or 1.8 kilograms in a 3-day period is a cause for concern. You want to assess for worsening edema, assess blood pressure every 4 hours. Assessing for progression of the disorder and allowing for early interventions to ensure maternal fetal well-being. Assess deep tendon reflexes and clonus. You want to have the patient on a moderate sodium, high protein diet. You want to monitor urine volume and proteinuria. This is an indication of how well the kidneys are perfusing. You also want to assess fetal status continuously. Another high risk factor is gestational diabetes. Multiple gestation patients are at higher risk, and this may be a result of 2 placentas or increased placental size, which increases the resistance to insulin. Some interventions for these are regular prenatal visits. You want to assess weight gain, monitor blood sugar, assess fetal heart tones for variability and accelerations, instruct the mother to lie in a left recumbent position after eating, and count the number of fetal movements in an hour. You want to have greater than 5 fetal movements. Also, the patient should be on a proper diet of high quality foods, and you want to teach the patient on how to use her insulin properly and effectively. Another complication is placenta previa. Multiple gestation pregnancies are at higher risk for this as well. And this is where the placenta is covering the cervix, the os of the cervix. So some interventions for this is you want to assess for blood loss and pain. With placenta previa, they don't normally experience pain in their abdomen. You want to monitor uterine contractility, both subjectively and objectively. Monitor for vital signs. Evaluate fetal heart rate with continuous fetal monitoring. You want to type and cross-match blood. Monitor client very closely. Abruptio placentae is also a risk for multiple gestation, and that is when the placenta separates from the uterus and can cause major hemorrhaging. And so some interventions for that is very similar to placenta previa. You want to monitor the vital signs closely. You want to assess the woman for signs and symptoms of disseminated intravascular coagulation. You want to monitor fetal status and uterine activity by continuous fetal monitoring. And you want to weigh the pads and chucks and document the bleeding, how much she is bleeding. Some intrapartum complications. They are at increased risk of cesarean section, increased risk of postpartum hemorrhage, increased risk of preterm labor and birth, malpresentations of the fetuses, premature rupture of membranes, and retained placenta. Some intrapartum management. You want to make sure the patient has an IV with a large bore needle in place, anesthesia and cross-match blood readily available in case there's hemorrhaging, and you want to have continuous dual electronic fetal monitoring. Some fetal complications of multiple gestation is prematurity, intrauterine growth restriction, congenital anomalies, increased cord accidents and prolapse cords, abnormal presentations. They are more likely to have long-term disabilities, Cerebral palsy is more common in multiple gestations than in single pregnancies, and so is Down syndrome. Vanishing twin syndrome, conjoined twins, TTTS, and encephaly. Some psychosocial effects that the mother may um, experience: exhaustion by carrying two fetuses instead of just one, feelings of being overwhelmed at the thought of taking care of two babies at one time, and also feelings of excitement. Some pharmacological treatments that the mother might need is betamethasone. It's a steroid. It is used to promote fetal lung maturity because twins are normally born prematurely at 37 weeks or less. It is given IM. It is contraindicated in chorioamnionitis. Some things you want to watch for: monitor for hypertension, hyperglycemia, and weakened immunity when they're on betamethasone. Because of the weakened immunity, you want to advise the patient to stay away from known infectious individuals. Avoid vaccinations without first consulting with the provider. And you also want to review side effects of betamethasone. Another pharmacological treatment is magnesium sulfate. This is a tocolytic and an anticonvulsant. This is to help prevent preterm labor and prevention of seizures, prevent eclampsia. It is given in an IV bolus over 20 minutes. And the one thing you want to really watch for is respiratory depression. And you want to teach the patient the purpose of the medication. In addition to those medications, you also want to make sure the patient is taking her prenatal vitamins daily, and make sure that she's taking folic acid 1 milligram daily to prevent neural tube defects. Some resources that the patient can turn to if they have any questions or concerns and that are helpful. One I found is Medela.com, specifically breastfeeding twins. Also, March of Dimes has some really helpful information on multiple gestations. And they can also ask their OB or provider or midwife any questions or concerns that they might have. Thank you very much.